Hello everyone, my name is Christian Macari and I will be broadcasting today this webinar for you from Beirut, Lebanon. Before I start with the actual webinar presentation, I would like to thank Dental XP for giving me the opportunity to present my material on such a fantastic online educational platform. I would like to thank mainly Edi Salama, and also I would like to thank Tyler and Pana for their technical support throughout the preparation of this webinar. Also, allow me to acknowledge the oral surgery department team at St. Joseph University for giving me their support that allowed me to work on all of these clinical studies I will be showing today to you. More specifically, I would like to thank my colleague Dr. Abdullah Manhal, who assisted me in most of this scientific work also. Going back to our webinar, I will be talking today about sinus floor elevation, and I will discuss with you the clinical overview of this technique, where we will be talking about different techniques such as external sinus elevation or internal sinus elevation. We will discuss the radiographic aspect of this procedure, the importance of radiographic examination in order to plan or to follow up sinus floor elevation. And finally, we will talk about biomaterials and histological aspects related to biomaterials. We all know as clinicians who are involved in doing implants that any time we are facing a posterior maxillary edentulous patient, we have to bear in mind that there is a strong possibility to have a pneumatized maxillary sinus, as we can see in this radiograph. There is an interesting study that was published by Song and co-workers lately, who calculated the prevalence of sinus augmentation associated with maxillary posterior implants. And the authors found that out of 502 implants that were placed in the posterior maxilla, for 54% of these implants were associated with sinus augmentation, which is a huge amount, considering that more than half of our implants in this region will need a certain type of sinus floor augmentation. This is why I think that this is sinus elevation is a very important clinical issue that every clinician who is willing to place implants should be aware of. And this is what I will try to explain during this webinar. We know that many years ago, like 1992, at that time I was still oral surgery resident in Paris, they started talking about pterygoid implant. I know that some people are still doing pterygoid implants, but the idea beneath those technique was to avoid sinus floor elevations. Also today, tilted implants are still used and still fashionable. And we all know today that there is no problem for a tilted implant to osseointegrate and behave as normally as a straight implant. The problem may be with some biomechanical problem may be related to prosthetic rehabilitation, but these implants are an alternative to sinus floor elevation that actually work. Also, there is this great technique that was introduced by Paulo Malo, the all-on-4 technique. I'm sure you're all familiar with this technique, and one of the main advantages of this technique is that it will allow us to place our implant in the maxilla without having to go into the sinus by just tilting those implants. Another alternative to sinus floor elevation is the use of short implants. And a lot of studies show today that short implant can be used as predictably as longer implant. And there is a very nice webinar that was presented on Dental XP 2 weeks ago by Professor Homazadeh from USC, who talked about the importance of short implants. And one of the indication of these implants will be below the sinus whenever we have residual ridge that is 6 to 8 millimeters. And you can see on the right this radiograph of a wide short implant that with a follow-up of 5 years, and we have no bone loss and everything is working fine. But the topic of our webinar today and what I will explain is sinus floor elevation. And the first technique was described by Tatum in 1977, and he started talking about accessing the sinus by a external window. And once we access the Schneiderian membrane, we can start elevating it, placing our bone graft inside of it. And once the bone graft is placed, we can, depending, and we will discuss it later on the residual ridge, place our implants or delay our implant placement. If we go back to the Sinus Consensus Conference that was held in 1996, and we look at the report of this Sinus Conference, they divided at that time the indications for sinus floor elevation depending on residual bone height. And we see that whenever we had less than 6 millimeters of bone height in the, beneath the sinus, the Consensus Conference recommended to perform a external sinus floor elevation, a lateral approach with grafting. And whenever we had more than 3 millimeters, 4 to 6 millimeters of residual bone, implants were placed. And whenever we had 1 to 3 millimeters of residual bone, delayed implant placement was done. So we will focus at the beginning of this webinar on this part of indication, which are lateral sinus graft. One very important step anytime we have to plan our sinus floor elevation is radiographic examination. And since the sinus is a closed cavity that we cannot see usually clinically unless we do an endoscopy, for example, it is very important to do whatever new radiographic techniques that can help us detect any abnormalities or pathologies or anatomic structures inside the sinus. And lately, the European Association of Osseointegration, in a consensus workshop that they organized, they recommended the use of cone beam computed tomography each time we have to do a sinus floor elevation in order to have information on arterial channels in the lateral wall of the sinus, and we will discuss about it, the presence and extent of septa, and also we will see the importance of septa in sinus elevation, as well as the health of the sinus, such as absence of sinus membrane thickening, polyps, or fluid levels. Manji and co-workers, in a very recent study that was published in Implant Dentistry, examined 275 patients who were considered for sinus augmentation. And they found out that 45% of the scans that I exhibited sinus pathology, which is a huge amount. In 56% of patients, there was a mucosal thickening that was superior to 5 millimeters, and in some instances, this may be considered pathological. 28% of polypoidal thickening, almost 9% of partial opacification, and or the presence of air and fluid level, and 6.5% of complete fill or opacification of the sinus. This is why it is very important to do this radiographic examination in order to rule out any of these pathologic conditions that can complicate our sinus floor elevation. You can find, for instance, if we take some examples, some mucus retention cysts. Usually those cysts contain some fluids. It's not infectious nor inflammatory, but it can complicate the sinus surgery when you elevate such a cyst. So you have, in most of the case, to treat those conditions before placing our graft. We have the problem related to mucosal thickening, and you see on the left we have a dramatic thickening of the membrane, I would say. I had in this case 19.5 millimeter of membrane thickening. And even though I got the ENT clearance on grafting this sinus, because this thickening was due to an old infection and it's no longer infected today, if we try to elevate such a membrane to place another 20 millimeter of bone grafting beneath it, we will end up closing the whole sinus and closing the ostium that you can see here. And this is the most important part of the sinus, because it gives the sinus its physiological activity, and it will keep it healthy if it's open. To the right you can see another mucosal thickening, but in this case the thickening is around 2 to 3 millimeter. And if there is no infectious sign that are mentioned in such cases, we can proceed with our sinus floor elevation without any problem. Sometimes we have the presence of pus or fluids, like you can see here. And here we have to definitely go by an ENT consultation in order to rule out any chronic or acute sinusitis. We can have some foreign body inside the sinus. You can see here some foreign body. Usually it can be some root fragments, or it can be some material from previous endodontic treatment that can be encapsulated and lead to some infection or some aspergillosis, for example, that can complicate also our sinus floor elevation technique. Once we've ruled out or detected any pathological problems into the sinus, we have to try to see what are the residual bone height that I have below the sinus. Because as we saw in the consensus conference on the sinus report, residual bone height is very important for us in order to decide on whether to place our implant immediately or perform a delayed implant placement. So on these CBCTs we can accurately measure the height of residual bone height. Also we have to detect some abnormalities like the Underwood septum, which is an anatomic variation that can lead most of the case to a tearing of the membrane, of the sinus membrane. Septa were, in some studies, were present at 44%, like Lana and co-workers. In some other studies, we had like 28% of cases with septum, which is also a very significant amount. So we have always to detect the presence of this septa, because their presence will complicate our sinus floor elevation. As you can see on this picture, you see this is my sinus elevator, curette, and this is the membrane that I'm trying to elevate. And you can see this septum that goes inside the sinus, and it's like a blade. It is a very thin and very sharp piece of bone that can easily lead to a tearing of the Schneiderian membrane of the sinus. This is why you have to detect it before doing the actual elevation technique. It's important also to see how much thickness we have in the buccal plate. If we have a very thick buccal plate, as you see on the left, it's like 2 millimeters of thickness. In some other instances, we have very thin buccal plate that is less than 1 millimeter, for instance. And the thickness of the buccal plate will always help us determine how difficult our surgery, our access to the Schneiderian membrane would be. Also, we have to detect some arterial channels. And as you can see on this CBCT cut, you see this small arterial channel that you see here. You can see it here. We all know today that the vascularization of the sinus, more precisely, like this human dissection that was done by my friend Nicole Jahan, was published by her and by Professor Carpentier in Paris, they describe the vascularization of the posterior part of the maxilla. As you can see, this vascularization is done by the inferior orbital artery in the anterior part of the posterior maxilla, and by the posterior superior alveolar artery in the posterior part of this maxilla. And those two arteries are linked together by two anastomoses, one external anastomosis and one internal or intraosseous anastomosis. And this is the arterial channel that interests us whenever we have to access the sinus buccal bone. We can see it here clearly on this CBCT reconstruction. You can see how this anastomosis comes out from the inferior orbital artery, and it goes throughout the bony window, and it links again the posterior superior alveolar artery. In an ongoing radiographic study where we assessed anatomic risk factor associated to sinus floor elevation using CBCT, we did at the university try to detect radiographically this artery, and we detected it in 82% of the cases, which is 28 out of 34 examined sinus. In contrast, some other authors like Rosano and co-workers detected it in 47% of cases, Kang and co-workers in 64% of cases. Maybe we had a higher visualization of this artery because of a more accurate radiographic technique, or maybe it's because it's CBCT when compared to CT scan, normal CT scans. The mean distance between the artery and the floor of the sinus was 11.7 millimeter in the premolar region, 10 millimeter in the first molar region, and 12.6 millimeter in the posterior region. It is important to note that in all of our cases, we had no hemorrhagic complications that was noted during the surgery, which means that we never really complain about an hemorrhage that was threatening or that was very annoying for us during the surgery, even though the artery was here. You can see it here clinically. You can see radiographically on the left the artery in the thickness of the bone, and once we cut this bony window and we took it out, you can see the path of the artery in the thickness of the bony window, and you can see the actual artery here that is in very close contact with the Schneiderian membrane. Now, this is, I like to show this, this video clip to tell you how we used to access our sinuses before. We use, and I'm sure that a lot of people are still using drills. We're not using drills anymore. I'll show you that we now use piezoelectric devices to access the window. But to tell you that with a drill, we can always manage to take out the bone and access the Schneiderian membrane, but there is a risk to perforate the membrane because drills are more aggressive. And especially also with a drill, you can always hit this arterial channel that we have inside the bone, as you can see here. You see that we hit this artery and we had some hemorrhage during our surgery. It's not threatening for the patient, but it can be annoying for us when doing our surgery. This is why today we use the piezosurgery in order to access our implants. This technique was described by Tommaso Vercellotti in 2001. And this technique, we start first of all by scraping the bone in order to reduce the thickness of the bone, and this is in cases where we have a thick bone. You can see here, following bone scraping, we have a more or less thinner buccal bone that is left, and now it's easier for us to use a diamond insert on a piezosurgery device in order to cut this bony window. We don't have to cut it in a thick bone anymore, you cut it in a thin bone. it's a very safe procedure. In some other cases, we can use a saw-like insert in order to cut the bony window. These inserts are more aggressive on bone, and if you are not very familiar with this technique, I prefer that you start with a diamond insert before starting using this micro saw insert. So once we could access our window and take it out, you can have a direct access to the sinus membrane that can be detached using a reverse cone insert on a piezosurgery device also that will detach the membrane from its bony environment, and then using some sinus elevation curette we can start elevating this membrane. And once we've done the elevation, we go to the last step of this surgery, which is filling the sinus. And it's important to see that in these cases, I always start by filling the distal part of the sinus. Then I fill the mesial part of the sinus, the upper part, and as you can see here, this is the palatal bone that we can very clearly see. And we are sure now that we fill this part, we fill that part, and we fill the upper part of the sinus. And this is when we can now continue our procedure by filling the whole sinus. And this is how we can be sure that we did fill the whole sinus. I will show you a clinical case to understand a little bit more this technique. You can see this sinus, the left maxillary sinus. We have a septum, a very high septum. But in these cases, when the septum is that high, we can consider that we have two different sinuses. And you can see here on this cut that we have one sinus in the anterior part and another compartment in the posterior part. And since we need to graft this premolar region and this molar region, we don't have to graft this part of the sinus, so it will be easier for us to only fill the interior part of this sinus that is divided by the septum. When we look at this cut, you can see that we have no residual ridge, almost 1 millimeter, so it will be impossible for us to place the implant immediately. This will be a delayed implant placement, so we will only graft the sinus. You see that we have more or less a 2 millimeter thickness of the bone, so we have to maybe scrape a little bit this bone in order to make it thinner before we can start cutting it. So once we've accessed our bone, we start with this insert to do some osteoplasty of the bone. You can see how I'm taking out the bone away. We have a lot of bone chips that we can use and incorporate to our graft. We continue with this process until we can judge that our remaining bony buccal plate is thin enough to be easily cut. You can see that now we can visualize by transparency the sinus. It's this bluish appearance of the bone is due to the fact that the bone is very thin now, and this is the bluish appearance of the Schneiderian membrane that you can see. Now in this case, I did not use a diamond insert. I prefer to use immediately the micro saw insert. I find that this insert is it's quicker because it cuts in a quicker manner. But as I told you before, it can be a little bit aggressive on the Schneiderian membrane. If you're not really familiar with this technique, I prefer that you start using a diamond insert. And all the manufacturers have diamond inserts that can be used over their piezosurgery device. So I did the lower border of the window, and then I did the upper border, and now I'm doing the mesial and distal part of this rectangular window. The shape of the window is not a matter. You can do it in a rectangular shape, or you can do it in a circular or oval shape also. you can see that in this case my sinus is more like a rectangle. This is why I felt that it was better to cut something that looks like a sinus. So here you can imagine that I have the distal part where I have my little pointer. This is the distal part of the sinus. This is the mesial part of the sinus that is here, and this is my cut. So now that I have properly did my limitation of the window, with a special curette I can start taking out this bony window. So you have to go very slowly in order to avoid any perforation of the membrane during this process. And then you push gently until this part of the bone is broken. You can then take it out and have a direct access to the underneath sinus. Now with the reverse cone insert, I will start to detach the Schneiderian membrane from its bony environment, the internal part of the maxillary bone, and this will facilitate our actual elevation process that will follow. Once we detach it, you see with this instrument we can detach it on a 1.5 to 2 millimeter of depth below the margin of the cut. We will have less tension on the membrane. Then we can start using those different shapes curette. This curette has a shape that goes for the proximal area. I start by detaching in the mesial part of the sinus, and you can see that here I'm hitting on the bone. I go inside until I reach the bone, and I follow my bone, doing a very smooth elevation of the membrane. Also on the distal part, I try to elevate the membrane by also always following the bone. And you see that I start going to the middle part of my sinus, and I continue detaching. It is very important when you detach the membrane and you elevate it to do it from different parts, to do it mesially, then distally, then in the middle. You don't do it only in the middle, for example, because then you will have tension on the mesial and the distal. So now that I had some more detachment of the membrane, I used another sinus membrane elevator that can help me to reach the buccal, the palatal bone. I have to reach this part of the bone that you can see on the right on the radiograph. So I went like this, and I go all the way to the palatal part of the bone. Now that I elevated my membrane mesially, distally, buccally, I continue all the way to the palatal part of the sinus. And you can see that once I completely elevated the membrane, that we have the breathing movement of this membrane. Whenever the patient breathes, the membrane moves with him. And this means that it's properly detached now. And usually when we don't have any tears in the membrane, it will move properly. When we have perforation, it will not move. I did some washing of the interior of the sinus with metronidazole. There is a publication by Shukroon on this topic, who talked about the importance of metronidazole to be incorporated with the graft and washing of the sinus with metronidazole in order to avoid some anaerobic infections later on inside the graft that can lead to some resorption of the graft. So I start filling my sinus with biomaterial. In this case, this is beta-3 calcium phosphates that I'm using. And as you can see, it's very important, as I told you before, to fill the sinus mesially, distally, and go all the way then to the palatal part. So you see that once I pack my biomaterial, and then with a curette I pack it again in order to be sure that I hit the most distal part of the sinus, to be sure that I went all the way to the palatal, and now I'm filling a little bit more to the mesial, also to be sure that I filled it properly. And I add some more biomaterial and I'm all done. So once the sinus is completely filled with biomaterial, it is important to cover the buccal part of this window with a membrane. We will discuss later on what happens to this membrane. Is it important to put some tags in? I usually don't put tags, but I think it's more efficient to stabilize this membrane with tags in order to avoid any movement of the graft, and we will see it in some of the radiograph I will show you now. So now that this procedure is done, you can see here that I did elevate the membrane and I did fill properly the needed part of the sinus. What's important to see also in this radiograph is the thickness, the new thickness of the membrane that we can have. You see the thickness of the membrane was almost 1 millimeter or less than 1 millimeter here, and now we have more than 7 to 8 millimeter of thickness. This is due to the fact that there are some inflammatory reaction that goes on inside the sinus after our sinus floor elevations. And this was a topic that we are working on at the university, at the oral surgery department. I did some radiographic work with some of my colleagues to see what actually happens inside the sinus after our sinus floor elevations. And here I'm talking about early inflammatory reaction. And we divided this inflammatory reaction in 3 types of inflammation. Mild, that you can see on the left, this is where we had a little bit thickening of the membrane, but there is no dissociation of the grafting material. There is everything is going fine to the sinus. A moderate, this is when we had a little bit more thickening of the membrane, but also we had some inflammatory exudate that we can see between the bone particles that are pushing the bone particles away from each other. And what we have on the right is a severe inflammatory reaction. In this case, you see that we have a very thick membrane. And what is more important is the huge amount of inflammatory reaction that occurred inside the graft. And you can see that some of the grafting material is thrown away by outside the window, as if a type of hurricane occurred inside this sinus graft. So what we did is that we monitored this inflammatory reaction for different patients. And each patient who undergoes a sinus floor elevation had to do a post-operative CBCT in order to monitor this inflammatory reaction. For some patients, we did it at 1 day. For another group of patients, it was done at 2 days. For a third group, it was done at 3 days. And for the fourth group, it was done at 7 days. Surely, each patient received 1 radiograph. We did not do the whole radiograph for the same patients. It was divided in 4 groups. And you see, what is interesting to see is that at 1 day, we had 43% of mild inflammatory reaction and 57% of moderate inflammation, but no severe inflammatory reaction. Membrane swelling, mean membrane swelling was 7.5 millimeter. At 2 days, we had almost the same for the 3 parts. We had 33% of mild inflammation, 42% of moderate, and 25% of severe. So we start having some more severe inflammation at 2 days. And membrane swelling was 11.25 millimeter. At 3 days, we did not have any more mild inflammation. It was either moderate in 70% of cases or severe in 30% of cases, with a membrane that was a mean swelling of the membrane of 13.3. And at 7 days, also, we did not have any mild inflammation. We had less moderate inflammation, which was 25%, and we had mainly severe inflammation, which are 75%, with a membrane swelling of 12.9 millimeter. And this is very interesting to analyze, because there are not a lot of, maybe there is 1 or 2 publications in the literature talking about early changes after sinus graft elevation in the membrane or in the graft compartment. And we all know that inflammatory reaction reaches its peak after 2 days after the surgery, and this is why maybe we had at 2 to 3 days we had more inflammatory reaction, and this is why at day one, we had less inflammatory reaction. But what interests us is what happens after 6 months. And you can see the same patient at 48 hours. You see this huge amount of severe inflammatory reaction with filling of the sinus, with membrane thickening. You can see how there is this exudate or fluids or hemorrhage inside the graft with some movement of the bone particles. And you look at the same situation at 6 months. There is no more thickening of the membrane. There is no more exudates inside the graft. Everything came back to its normal nature. Same here at 48 hours. Look what happens to the membrane. We had so much inflammatory reaction that this membrane moved totally away from the bony window. It was vertical, it is now horizontal, and it's very interesting to see these images. This is why I told you that after seeing these images, I always recommend now to tag the membrane that you place over the bony window of your sinus if you don't want to lose it due to inflammation. And you see that at 6 months, everything came back to its normal place. The biomaterial that was thrown away from the graft is still out on the buccal plate, and you see that you have some blood coagulum that occurred, and maybe it will be transformed into bone. This is another case. You see at 3 days how we had this hemorrhagic or fluid release of fluids inside the graft, and you see how this fluids occurred inside the graft, and you see how the graft did not go into the sinus because it's still encapsulated by the membrane. This is a very nice and interesting radiographic image to see. And you see at 6 months, everything returned to normal. This is why we tried to calculate what happened to the membrane thickness at 6 months, and we were very relieved to know that at 6 months, mean membrane thickness that was ranging between 7 to 13 millimeter is now 0.7 millimeter. So everything returned to its normal path, and this is very relieving. Another complication that can always occur during sinus floor elevation is Schneiderian membrane perforation. And this is what it's the nightmare of every clinician who is willing to perform a sinus floor elevation, is having a perforation of Schneiderian membrane. This perforation can occur during bone preparation or during membrane elevation. It is different if we use rotary instrument or piezoelectric instrument. The risk factor is significantly higher when we use rotary instrument. You see, if we combine the studies that we had between 11 and 56% of reported perforation in the studies with rotary instruments, and we had from 0 to 30% of perforation when using ultrasonic instruments. Some authors reported that we had more implant failures when we had perforation of the membrane, like Khoury or Prusayev. And some other, like Froome, reported that membrane damage, when properly repaired, did not appear to be an adverse complication in terms of vital bone production, for example. We could, if we can repair it, and we will show the technique to repair, we'll see the technique to repair it, you can have some very predictable bone graft. What about our experience with membrane perforation? In a retrospective analysis of 65 consecutive lateral sinus floor elevation, we had 5 perforation of the membrane, which is 7.6% of cases. And in all of our cases, we use piezosurgery, ultrasonic instrument, which means. In 4 of the 5 cases, we had the presence of the septa. This is to tell you that the highest risk factor for membrane perforation is the septa. And also, in 4 out of the 5 cases, we reported a thin Schneiderian membrane, and this is the second most important risk factor for perforation of the membrane, which is a thin membrane. Only in 1 case, we had this membrane perforation during osteotomy, and only in 1 case, the surgery had to be postponed. In all the 4 other cases, we could repair the membrane perioperatively and go on with the surgery. You can see here, this is a membrane perforation that occurred after elevation of the membrane. You see that is a thin biotype. Usually we continue, we go on with our elevation, we place a collagen membrane in order to close this defect, and we put our graft. And we have, in all of the 4 cases we treated this way, we did not have any graft complications. And this is the one case that I will show you where we have a very sharp septum, and this is one big risk factor for membrane perforation. You can see that in these cases you have to imagine the presence of this septum, and with a ultrasonic device I usually scrape the bone away. I take the bone away until I can see and I can localize the septum, and then I start elevating the membrane gradually. It's a very, we have to be very patient in this process until we can elevate the whole membrane, and you can see the septum, it's very sharp like a blade here in the middle of the sinus. Then we fill the first compartment that is distal to the septum. We fill the second compartment that is mesial to the septum, and you can see radiographically how we could achieve predictably a complete fill of our sinus. Now that we properly discussed, I suppose, all the radiographic part of sinus floor elevation in planning and in doing the proper follow-up of the graft, after we discussed the clinical technique, what we use and how we use our technique, we will talk about biomaterials. It is very important to understand your biomaterial, because at the end of the day, if you put a bad biomaterial into your sinus, you will end up having no bone or bad bone or something that will not allow your implant to osseointegrate. We know that there are different types of biomaterial. You can use autogenous bone from the patient, but usually, especially when the sinus is has a bigger volume, you will need a lot of bone, and this has a lot of morbidity on our patients. This is why we recommend today to use particulate biomaterials, and we have mainly 3 different types of biomaterials, which are allografts, which are biomaterials from human origins. We have banks that give us human bone as particulate graft that you can use predictably into the sinus. You can use xenograft, which are hydroxyapatite of animal origin, and we all know that one of the mostly used biomaterial in the sinus is bovine hydroxyapatite that showed to give very predictable results, and I will show you some clinical and histological results of it. And the third type of biomaterial that we can always use is synthetic biomaterial, and the most important synthetic biomaterial we use in the sinus are bioceramics, like beta-tricalcium phosphates or hydroxyapatites or blends of beta-TCP and HA. As a clinician, before going into the details of histologies or the behavior of biomaterial, whenever we need to graft a sinus like this one, where we have a very low residual ridge of 1 millimeter, we fill our sinus, and we come back 6 months later to drill into the sinus and place our implant. What interests us is to have a bone that is hard, that is similar to natural bone, where we can place predictably our implant and without having any problems. And in this case, this was a case with bovine hydroxyapatite. I placed our implant, and I had a 90 Newton insertion torque, which is something very, it's a very high insertion torque in the posterior maxilla. When you use this type of tapered implant, you can easily have high insertion torque, but not in a grafted sinus. And you can see that I had a primary stability that is also very high, with an ISQ of 83 when measured by an Austere machine. This is why I could predictably at 6 weeks restore this implant, and you see the follow-up is marvelous for this implant. But do we always have this type of results when we graft our sinus? Unfortunately, no. Do we always need this type of bone each time we have to graft our sinus? Also, I would say no, we don't need. We need something, we need enough bone, viable bone, to allow us to place our implant, to achieve a proper primary stability and insertion torque, and to have a living biological bone that can lead to osseointegration of our implants. But the only way to understand what happens into the sinus and what happens inside every sinus we graft is to be able to retrieve a biopsy from each sinus. Because each sinus is unique and each patient is unique. A biomaterial that works fine in one sinus will not work the same in another sinus, because also you should know that there are some factors related to the patient, related to the sinus structure, to sinus anatomy, to the way the surgery was performed, that will lead to lower or higher vital bone inside our graft. And once we retrieve this biopsy, you can see here on at the cervical part of the biopsy, this is the residual bone, and this is the whole graft. And the more we go apically, the more we need to know if we have some new bone formed, yes or no, because this is where usually we have less new bone formation. And the only way to understand this is to try to see this in a histological way and understand what histologically happens inside this trifine bone. And this is the actual histology of this bone. You can see those, this is the biomaterial. It's a bioceramic in this case. And you see the bone, newly formed bone, between those bone particles or sometimes in contact with these bone particles. And the more you go apically, we can still find that we have a lot of new bones formed in this biopsy. In cases like this, you can be more confident about the biomaterial you use, because it is a biomaterial that could achieve its properties. And the main property of a biomaterial is to maintain the volume stability. This is why we need a biomaterial that will not resorb immediately. And you can see that we have a volume stability in this biopsy. The second important property, biological property of a biomaterial is osteoconduction. A biomaterial should allow bone to form in contact with its particles. This clinical case is very interesting. In this case, I had a sinus that, a huge sinus that I had to graft with a bovine hydroxyapatite. This is the case before, this is the case after my sinus graft. And you can see that the patient had a very nice temporary bridge, and he was very happy with his temporary bridge that he did not come back until 3 years later when he lost his temporary bridge, or the tooth that was supporting his temporary bridge. We were lucky at that point to be able to retrieve biopsies of a sinus that was grafted 3 years earlier. And when we took this bony trifine, we could analyze in detail what's going on inside. And you see that we have a tremendous amount of new bone formed in this bovine hydroxyapatite. You can see that even at 3 years, we still have, as you can see here or there or here, you can still have those particulate graft particles that we placed. They are still there, but you can also see that they are totally englobed with new bone formation, and we have a lot of new bone formation, which means that this biomaterial could achieve volume stability. It is resorbing, but on a slow rate, and it is osteoconductive, allowing for new bone formation inside the sinus. And this is the type of biomaterial that I usually need to have whenever I am coming back to place my implant into a sinus. Also, if we want to talk a little bit about bioceramics, HA-beta-TCP, for instance, this was a micro-CT and histological study that was done. I did with my colleagues at the oral surgery department in Beirut. We did this study in humans where we performed 8 lateral sinus floor elevation using HA beta TCP blend, 60 to 40%, with two different types of graft, granules or aggregates. This study was supported by Eurocoating in Italy, and they provided us with this bioceramic biomaterial. We always use a collagen membrane to cover the window, and we did a trifine biopsy at 6 months in order to analyze how much vital bone we had inside this graft. And if we look a little bit on the histological result, you can see this is the particle of HA beta TCP, and this is the new bone that is formed around this particle. And you see that in these cases, for instance, we had a very nice bone-to-particle contact, bone-to-graft contact. You can see here new bone formation and the contact of the graft. This is the bone, and this is in red we have the new bone, because whenever the graft was resorbing, new bone formation was taking its place and was forming around it. Also on scanning electron microscopy, you can see the nice bone to graft contact here. You can see on a microradiograph how we had osteoconductivity of such a biomaterial with a lot of bone particles. Also on a micro CT here, you have a lot of bone particles, bone formation between the particles that we had. In our series, we had 21.4% of new bone formation in aggregates and 20.8% in granules, which is almost similar to the results that we find in the literature. Usually it goes from, with different biomaterials, even with bovine hydroxyapatite, we are almost between 18 and 25% in different, if we see what exists in the literature usually. But if we want to discuss a little bit this bone volume that we had. Recently we had a published article when we retrieved some trifine biopsy at implant sites in order to analyze the bone where we placed our implants. And one interesting thing is that we found that mean bone volume in the posterior maxilla was around 28%. And we had, of course, soft bone, which is D4 quality bone. And if we try to compare this biopsy on the left, which is a biopsy of a normal maxilla in the posterior part of it, to this biopsy on the right, where you can see an HA beta TCP trifine biopsy of a grafted sinus with 24% of new bone formation. You could say that there are, if we compare new bone formation or total bone volume, we are very comparable. So maybe we don't need to have more than this. It would be perfect if we could have. It's not easy to achieve at 6 months a higher new bone formation unless we use some bone morphogenetic proteins or we add some other growth factors, for instance, to the graft. But this belongs to some future studies that are coming out in the literature. To conclude on biomaterial, I will show what the results of a histomorphometric meta-analysis on sinus elevation with various grafting biomaterial. And you see that they tried to see the correlation between total bone volume inside the graft and time after grafting. And you see that with autogenous bone, interestingly, we had a very high bone volume at the beginning that had tendency to diminish because autogenous bone usually resorbs when you put it into the sinus over years. On the contrary, when you try to analyze beta TCP or bovine hydroxyapatite, you will see that we had a lower bone volume at day 0 that went up at 6 months to something like, you can see here, we were about 17 to 21, 22%, and these results are very similar to the result we had in our study. But if you go on and analyze this over the years, you can have higher results of beta TCP, of total bone volume in beta TCP and bovine hydroxyapatite, which is something that it's sort of relief for us because we know that our biomaterial is in continuous transformation. And we are working at the university on retrieving biopsies at 12 months in the same case series I showed you earlier. And I'm sure that we will have higher bone volume at 12 months, and maybe hopefully in another lecture on Dental XP, I could update you with our new results. So now that we're done with the first, that is the bigger part of this webinar, that is sinus floor elevation using a lateral approach, I will end by talking for the 15 or 20 minutes about sinus floor elevation using crestal approach. And you all know that this approach was introduced by Summers in 1994. It consists of drilling until we reach the floor of the sinus. Then, by the use of an osteotome, we could and some tapping, you can break this floor of the sinus, add some graft, and tap the graft until you elevate the membrane and place your implant. One very interesting article that I found in the literature was about the mechanical properties of the Schneiderian membrane in vitro. And there are two very important properties for this membrane that we should take into consideration when doing our sinus floor elevation, and mainly this crestal or internal approach, which are elasticity and detachability of this membrane. Because if this membrane is elastic, it will bear the pressure of the biomaterial without perforating. And if it is detachable, it will also, under the pressure of the biomaterial, it will detach by itself, allowing for an elevation of this membrane. I like this panoramic radiograph because it summarizes the difference between internal or external approach. You see on the right, this is an implant that was placed in a sinus after performing an external sinus lift. And you see, when we do an external sinus lift to place one implant, it gives us usually an enormous volume of grafting that we have to place into the sinus. In this case, we extracted these tooth and we will place an implant later on, not the same. So you see that we have this type of sinus lift compared to this type of sinus lift, where we placed one implant with an internal approach, and you see that in this case, bone grafting was really localized to this small area around our implant. And this is one of the advantages of internal approach, is that we use less biomaterial, and this biomaterial is really placed when we need it to be placed around our implants. In order to understand the surgical technique, I will show you this surgical video, where I have, in this case, a 5 to 5.5 millimeter of residual bone. So what I do in this case, instead of going with a external or lateral approach, I can do the crestal approach. So we start preparing our implant site. And one big advantage of ultrasonic device today is that we can do what we call an ultrasonic implant site preparation. And beneath the biological advantages of this technique, I will discuss here one main advantage, which is that when we use the ultrasonic device to prepare the bone under the sinus, we are more precise and we have less chance of perforating the Schneiderian membrane crestally. You see that here I'm using this diamond shape coated insert in order to grind as much as possible the cortical bone that is somewhere here, and that is an obstacle between my implant preparation and the sinus. So now you can imagine that we have a preparation that goes until it reaches the floor of the sinus, a grinded floor of the sinus, some bone that is placed here, and with the osteotome we start tapping the bone, and this bone will gradually, while tapped, break this remaining part of cortical bone and start elevating the Schneiderian membrane. As I said earlier, since the Schneiderian membrane is elastic and is detachable, the pressure due to osteotomes with added bone graft will gradually elevate this membrane until we reach the final elevation process that we need. And you can see you have to be patient, you have to go step by step. Each time we add some more biomaterial and we tap it until we reach, at the beginning, we only reach the 5 millimeter height that we have. But as we go more into the sinus floor elevation, we can reach more. So you see here that I had this radiograph that I usually take will help me detect where and how my biomaterial is being displaced into the sinus. If I see that there is a convex shape of the biomaterial under the sinus, as I saw in this radiograph, this means that my Schneiderian membrane is still there, and I can be sure that it is still holding the biomaterial. And here also you can see, if this is the floor of the sinus, this is my osteotome that's going now 6 millimeter into the bone. You see that now that I'm more confident and I know that I started elevating, I can insert my osteotome inside the sinus. It's going 2 millimeter into the sinus. And you can see here, and this is very important to see, this convex shape of the biomaterial that went into the sinus but is still englobed by the Schneiderian membrane. So when I look at this radiograph, I am sure that my graft procedure is going the right way. So I go on with this technique. I add a little bit more bone and I keep on tapping until I reach the desired elevation that I need. So I had 5 millimeter of residual bone and I need to place a 10 millimeter implant, for example. This is why I need to elevate the membrane of 6 to 7 millimeter to be able to insert my implant. So this is when I add the last part of biomaterial and I place my implant. And even the implant, while going in, will elevate a little bit more also the biomaterial and the membrane. And at this point we will take the final radiograph that will confirm to us if we properly did our sinus elevation. And you can see this is the residual bone, this is the implant, and this is the nicely elevated sinus membrane that you can see here. This is the result at day 0. And you can see here the result after placing the final crown and the implant in function. You can see that this bone is now more taking more the shape of a vital bone. The sinus is healthy and everything is going fine. Do we always need to graft when we do an internal sinus lift? Because there are a lot of authors that talk about placing implant without grafting. Like in this case, I just placed the implant with a tenting effect. I elevated the membrane and the blood clot that was formed between the Schneiderian membrane and the floor of the sinus was transformed into vital bone. There is this publication by Nadir and co-workers who talk about it, who showed that they could predictably lift up to 3 millimeter the sinus without using any bone graft. I will show you some cases. You can see here the result if I contrast the bone, where my implant was 1 to 2 millimeter inside the sinus. I had no bone, I have some bone formation, and you see at 6 months how much bone formation I have. And this is very typical of what happens when you can elevate the membrane without any perforation inside of it. Also here you can see I had 6 millimeter of residual bone. I placed the bone, just breaking this part of the bone that you can see here and elevating the membrane. And you see how at 5 years we had a very nice result. The bone was here and now it's here. So we could easily gain 2 millimeter of bone in these cases. Long-term results are very important also with this technique. You can see this result at 4 years. They are usually very stable. And as I told you, you have only bone on the part of the sinus that is in close contact with the implant. You see here the sinus is still normal. In contrary, when we do external sinus lift, we have to fill this whole area. This is one of the disadvantages in these cases. It is important for long-term result to have a procedure that is done without perforation. Remember that this is a blind technique. We can never know if we perforated the membrane, unless we do radiograph, or unless some cases we can have a perforation that was not detected, which will lead to an inflammation or infectious. So it is very important to be very particularly picky when we do this technique in order to avoid this membrane perforation. But the final question that I would ask is, where is the consensus? We saw that in the report of the Sinus Conference 20 years ago, they had a consensus that said that whenever we had more than 6 millimeters of residual bone, we could do this internal sinus floor elevation. And whenever we had less than this, we had to do a crestal approach, a lateral approach. So let's see some cases. Like this case, we have 5 millimeters. We perform the same technique I showed you. You can see how we have this beautiful dome of grafted bone inside the sinus. We placed our implant, and we could predictably elevate our sinus from 5 till 10 millimeters in this case. In other cases like this one, we had 4 millimeters of residual bone. Also using the same technique, you see that I drill until I reach the floor of the sinus. It's very important not to perforate the floor of the sinus with your drill, because you will also perforate the membrane. Unless you are using a ultrasonic device with a diamond insert, for instance, you can try to trim as much as possible this cortical part of the sinus floor in order to facilitate your osteotome tapping and biomaterial elevation. And you see, as I said, the elasticity, the touchability of this membrane that will englobe this whole biomaterial. And when we see such a radiograph, we are sure that we did a proper sinus elevation without perforation, and this is the implant placement. So we went from 4 millimeters to 10 or 12 millimeters also, predictably. In other cases where we have, in this case, 3 millimeters with a septum, you see that when I started my elevation, bone was going mesially to the septum, which is normal. And then I kept going up. And it's nice to see that on a certain point, the septum break, or maybe the graft went behind the septum, and we could have a very nice also dome radiographic shape of the graft with the osteotomes. And we could predictably go from 3 millimeters to 12 millimeters. This is the graft. We delayed implant placement in this case. This is 6 months later. We placed, and this is our implant, and after restoring the teeth and implant in function, you can see that it is a very also predictable technique on the long term. This is more cases where I went from 2 millimeters also, and in these cases it is more tricky, and but by always following the same technique we can achieve it. And this is the final case where you see that I started with 1 millimeter, almost no residual ridge. I will end with this case. Also by following the same surgical technique that I described, which is trimming the bone a little bit, especially by using very fine inserts, diamond insert, ultrasonic inserts, for instance. We can trim the bone without having to perforate the membrane or harm the membrane. You can see here that the membrane is moving when the patient breathes, which means that there is no perforation. So we start adding the bone and tapping it gently. And millimeter by millimeter, we keep going up and up and up until we can reach our desired sinus floor elevation height. So I tap, and then I place again some more bone inside this tapped area, and I tap again. And as I told you, it's a very gentle but a very slow process until we can reach this sinus floor elevation. So here also we went from 1 millimeter all the way up. So you can see that today, when we go back to this Sinus conference, we can see that there is no boundaries to any technique. What was true years ago is not true anymore. This consensus conference can be obsolete today, and this is why we will try to give our treatment options whenever we do a sinus graft elevation. So today, whenever we had the residual bone height of 10 millimeter, they used to preconize, they used to ask us to do some sinus floor elevation with osteotomes. We don't do it anymore. Of course, we place an implant of 10 millimeter, which is not even a short implant placement. It's an urban implant placement in my mind today. Whenever we had 7 to 9 millimeter of bone, we can use an osteotome, just break the bone, the cortical bone, and place an implant of 10 millimeter without having to put any graft. Or even if you have 8 millimeter, you can place an implant of 8 millimeter, especially if you can allow placing a wide implant. And it will be a very predictable implant placement. When we had 4 to 6 millimeter of residual bone, in this case, I always perform an osteotome added grafting sinus floor elevation, and I immediately place the implant. I don't have to do an external approach unless I need to place more than one implant in this sinus. Then it's maybe easier to open and do a lateral approach and place our implant, because internal sinus lift is more like a slow technique, and it needs more patience and time. It's time consuming. And whenever we had less than 3 millimeter, 1 to 3 millimeter of bone, I showed you in my case series that we could achieve a sinus floor elevation using the internal sinus technique, which is the osteotome. So it's also here it's a choice of technique, but I usually recommend doing the lateral approach, even though I showed you that the internal approach could be used in basically all cases that we had, but sinus elevation using a lateral approach is more appropriate when we had less than 3 millimeter of residual bone height, with also a delayed implant placement. If we had less than 3 millimeter, I don't really recommend to place an implant immediately, because sometimes you have some bone resorption in the marginal area that may lead to a loss of primary stability and may lead to also implant failure. And this brings us to the end of this webinar. I hope that I could answer all of your questions on a particular and very important surgical technique that is sinus floor elevation. I hope you will interact by the Q&A that are below this this webinar window that you will see on Dental XP, and we can maybe interact. You can always send me an email. This is my email. If you are passing by Beirut, this is our university, St. Joseph University. It's one of the oldest universities in the region, and we will be very happy to receive you and to host you in our oral surgery department here in Beirut. And thank you once again for your attention.